Hi, dear doctors. This is Dr. Shahriar. Going to start the session. Today's topic is on August recall. I hope everyone is in good health, and please let me know in the comment section from which city or country you are attending this particular session. Actually, all right. So it's good to have all of you back, and let's get started with the session going on. I'm going to share my screen now, definitely, and in this particular section, you get to see. Yes. That's wonderful. Please comment that, if you can see the screen very clearly. Okay. As per the comment, I can see that the screen is probably visible now, actually. All right. Still, I think it's a trial class. And so it's a trial class. So for how many is it the first class? Guys, please mention in the comment section for how many of you is this the class one? All right. I think for some people, this is the first class with us, actually. Now, please understand this particular course. Guys, I mean, a little bit interaction would be really good actually. For how many is it your first class or is it your second class? Dear doctors, please comment in the comment section. I mean, if you're in this batch, please comment in comment section so they get an idea. Is it the first class or the second class? Okay, that is wonderful, guys. You guys are wonderful. All right. Now here we go. Right now it's like a 7:30 Sydney, where maybe it's 7:40. Sydney is ongoing. So usually we prepare this particular time. Other than, if we add the country zone, it's always 3 p.m. India time. Then there would be 3:30 p.m. It's Bangladesh time and 2:30 p.m. Pakistan time actually. So, and we are going live now, of course. And we also take live classes. I mean, for 1 year plus, I'll be taking live classes. Like more than 1 year, I think I'll be taking live classes. And also, as recordings, we'll be giving you 5 years of recording contents actually, which I think already we have given to most of the doctors, unless someone has taken admission in last 24 hours. Other than I think everyone has been supplied the materials actually. In the materials, you will be also seeing some notes, especially known as a SMA note. Yes. All right. So that's another thing is a SMA note actually you can see. So if this is first time with us, I don't know how much theory you have finished. So in that case, I highly recommend you to go through the SMA note. If you previously, in our 5 months course, in past actually you already maybe finished the SMA note and you are here more for solving more recalls actually and more mastery in terms of the recalls actually. In order to be more master, at least like 3 years recall is mandatory. Then if you have more time, then another 2 more years is highly recommended. But without not doing at least like a 3 years month wise, it's like quite suicidal going for the exam. So it's a mandatory field actually. Guys, informations are important. I hope you're writing, or those of you are good in terms of remembering, that's fine actually. But it is better to have a pen and pad so that you can write important tips and suggestions. All right. Ebooks, I think most of you already having it actually. If not, like you can ask us like what are the ebooks of AMC. And otherwise we'll post in the group. So don't worry, check our video channel. After today's class, I'll be posting the um, MC ebook links actually in that case. All right. And in terms of the support group, as you can see, I mean, I hope you are familiar with the support group. It means no matter when is your exam, if it is in October, November, February, no matter when, we also take live class separately during exam. Okay, so during exam there will be live classes. All right, and we'll be trying to give you support. Uh, like for this during your exam actually, and it's very helpful and a lot of things are repeated from our discussions actually during the exam which is ongoing actually. All right, and of course we are using Zoom as our one of the platform, and I hope so you all are familiar with the Zoom. I usually recommend to use a laptop for the classes actually. Okay, so my requirement to have a laptop. If laptop is not available, then mobile. But I have seen statistics like Those are more with the laptop device or a desktop properly using the chances of passing is more higher. Whereas like using phone, iPad, and this thing fail in the exam mode. That's my personal some sort of databases of years. So yeah, because when you use laptop, your productivity increases. That is the only reason actually. For viewing, sometimes pads are okay, but day-to-day study, I mean to say day-to-day study while you are doing in the iPad, not recommended. Then phone, iPhone, Android phone, not recommended. You should definitely use a proper laptop device actually. Guys, if are you following me, please comment in the comment section if things are loud and clear actually. I want more to be interactive during the classes actually, as at least mentioning as a yes, copy that, it's really helps the mentor to, yeah. Now, here we go. And this is the WhatsApp number if you can contact us. Admission related any inquiries, you can also find me in Facebook, searching my verified Facebook ID, Shahriar Ahmed, SUGRY. That's the verified Facebook. I know it's a blue tick you'll find. And you'll see my WhatsApp. This is one of the WhatsApp. Me and my team both monitored that. So this is our official WhatsApp actually. With that note, I mean, we're going to start the August because this is the month of August. So we are doing the most latest one. Yes. So here we go with our first question. And I hope we can start now. 45-year man presents with a right-sided facial weakness, inability to close the right eye. I hope you're guessing what is this question is about. Great. Now, vesicular eruption of the pinna in auditory canal. What is the most likely causative microorganism? Now, a quick answer will be appreciated. This question considered a easy question. This kind of easy question does come in the main exam too. But many other difficult questions are also will be there at the same time. Great. So keep going, guys. Keep going. Keep going. Yes, please keep going. All right. Now, most of you must be understanding one thing. This is a Bell's palsy. Is it only Bell's palsy? Or I mean to say that Bell's palsy is of two types: upper motor type of Bell's palsy, lower motor type of Bell's palsy. Right. Now, our diagnosis would be it's a Bell's palsy. Diagnosis, it's a Bell's palsy. All right. And it's of two types: upper motor neuron type of Bell's palsy, lower motor neuron lesion type of Bell's palsy. All right, so we have to make a judgment at this point. Is it upper motor or lower motor type of Bell's palsy? Now, most of you probably thinking this is possibility. What do you think about the possibility, guys? Is it a? Is it a B? Is it a? What do you think? I think because there is a thing mentioned, vesicular eruption of the ear. So I personally think this is very higher chances, not like varicella. Definitely, it is not. We'll be thinking more this thing as a herpes is probably it is responsible. So herpes and this particular lesions are usually what do you think? Lower motor neuron type of lesion related to Bell's palsy. Is it clear to everyone? So this is kind of like a lower motor type of Bell's palsy. Lower motor type of Bell's palsy. Now, why do we understand? So this is Ramsay-Hunt syndrome. Why we think Ramsay-Hunt syndrome? Because two things: vesicular uh, eruption. One is a vesicular eruption, and plus Bell's. We think about like uh, Ramsay-Hunt. We think about the Ramsay-Hunt syndrome until proven otherwise. It's a very clear one. And this particular situations are lower motor, this type of elation. Now, then the question can come, why not upper motor neuron type of elation? Can anyone explain that particular part? Yes, we are coming to that particular part. Let me zoom this part. Now, if it is an upper motor neuron type of Bell's palsy, where our forehead part will be spared, means it will not be affected. Now, if we come back to this particular, if we come back to this particular area, yes, come back to this particular vesicular eruption. Yeah, vesicular eruption. Yes. So in that case, it is, yeah. So right side is facial weakness, inability to close eyes. All right. So and the wrinkle part that particularly will be spared. So forehead will be spared actually. So with the characteristics lesion, the viruses and all these thing. So the viral causes are definitely lower motor type of lesion, whereas stroke, which is causing lesion, is like a upper motor type of lesion actually, and that's one of the particular thing we look into. Yes, this is the thing. So if this is the face, if I draw it just to be clarify more. So in case of lower motor type of Bell's palsy, this all particular area would be affected. Clear, everyone? This is lower motor neuron type of Bell's palsy. Now, this is another one I'm trying to draw. In that case, the same one, let's say, this particular, this is the upper motor neuron type of Bell's palsy. Now, this particular area is spared. Is it clear to everyone so far? Everyone, is this clear so far? So very, very important. Yeah. All right. It's like a we thought about it, but it's actually we'll not think much about the varicella because this auditory canal thing. Because if it would have been varicella, if it would have been varicella, in that case there will be systematic involvement, systematic, more involvement. Clear now? Also, they will be telling you more about the relation. I hope that's clear actually. So varicella will be more systematic distribution. Herpes will be certainly some territory wise. I hope that is clear to the doctor. I think in that reference earlier it was a little bit mentioned about this varicella thing. But we'd like to go with this thing. This is a very popular question in the exam. This one's answer definitely is um, Bell's palsy causing by a virus. Now, a little bit extended thing if I ask you, what are some of the other causes of Bell's? I mean to say Bell's palsy causes. Bell's palsy causes. Now, certain other thing can be, yeah, certain other thing it can be. What do you think? Okay, one more thing. I mean, some people are still thinking as being, is your age group is supporting for varicella? Is your age group is also supporting for chickenpox? Probably. Uh, Not really. I mean, if it's a varicella, but the zoster one is even much later. If you think about the zoster, that will be much elderly age group, which is a different one. And speaking of the varicella chickenpox, that's in much earlier age group. In between the chicken poxes are, yeah, very less common actually. Okay, we're not going there. Herpes is not that one. Yes. It's not necessary that all herpeses can cause jaundice actually. That's another presentation actually. All right. Doctor, I mean, focus on the questions. When I mentioned that, this is like the answer, it's a very common one in the MC practice, actually. I mean, I'm not getting into argument with you, when we're telling, so you need to go with it. Actually, it's a very common question in the exam day to day. Let's focus. It's about like, you need to update and upgrade in that case. Uh, Focusing on that particular part, we are asking about some of the other causes of Bell's palsy. Other causes of Bell's palsy can be, let's focus now, guys. Uh, Please note about the Bell's palsy, if anyone has came through our 5 months course, we have details discussion on the Bell's palsy, including when the herpes is causing jaundice, when this, that thing, we have gone through it already. All right. At this point, we expect that you should know these things actually. All right. Now, many other things, including this tumor that can also leading to Bell's palsy, is also tested one time in the exam, right? So salivary tumor that can cause. Now, I would like to ask one thing: is it possible, like a bilateral um, Bell's palsy? Yes, someone is trying to recall that one. We speak in the about this thing in our 5 months course in past, like bilateral Bell's palsy. Okay, at least one we probably can remember that is like a salivary tumor, but there can be other causes of bilateral too. But here at least we remember the Lyme disease. At least remember the Lyme disease actually at least. Okay, so certainly if you come and if you see, there can be certain other causes of facial nerve palsy, seventh nerve palsy, like a so you can see Lyme, and this herpes zoster, sarcoid, all right, tumor, many other things. That's possible. But often the cause also can be idiopathic. Okay. All right, guys, let's move forward to the next one. And another question it can be presented, which we discussed in our 5 months course. Like in that particular question, there was Bell's palsy, plus there was jaundice was mentioned. Okay, so people are confused what can be the cause. It was actually again a lower motor neuron type of Bell's palsy. Why? Because that particular herpes virus, it's a rare possibility, not a very common rare possibility. It can affect the liver. Okay, and when the liver is affected, it can cause jaundice, but it is not universal that all herpeses are affecting the liver and always jaundice will be present. Now clear, everyone? Yes. I'll tell my like my expertise and this that throughout the course, so don't worry about these things. Great. Next one. You prescribe rifampicin in a 25-year-old woman for latent TB. This is one of the five-star topic, latent TB. Even though pulmonary TB, POTS disease, those things has been tested a little bit, but latent TB is the most important. What advice you'll give regarding contraception? Interesting. Yes, please. No answer. Okay. If this is the right answer, example, why it is that? In one line, you need to explain it. It's because rifampicin is a drug which is enzyme inducer. So I do have a formula. I do have a formula. You can say uh, how to use it. Um, enzyme. I hope you're writing enzyme inducer, uh, which actually induces cytochrome P450 450 enzyme and decrease activity of the other drug. Okay. Now here in this case, enzyme inducer is a rifampicin plus, which stimulate the cytochrome P450 and decrease activity of other drug. And here the other drug is a oral contraceptive pill. So eventually she will get pregnant because of lack of failure. Okay. So use traditional barrier during um, the contraception for the rifampicin actually. What do you think? So using the pill, will that work more? Using the pill, will that work? Because we have a very powerful rifampicin therapy. So it will be troublesome actually. All right. So best would be what? Best would be barrier. Is that clear, everyone? Again, OCP will fail. High dose of OCP will also carry a lot of side effects. So why to take some of those unwanted side effects? All right. Right. Um, Previously tested, let me tell you something about latent TB. My job is not to tell the son's answer this, but what different way latent TB has tested in past. Uh, if you see here, latent TB, there was a question in past. There was a incomplete vaccination history. Vaccination means that BCG vaccination history. And now the basic test, that is the tuberculin, has become positive, but not so significant. Not so significant. So for this reason, you did an X-ray, but this X-ray finding is bit inconclusive. Okay, inconclusive. All right. Um, if you take the history of the patient, patient is having cough for, 18 days, something like that. Again, number one, let's take a different color. Number one, in the past recall, incomplete vaccination history. Second point, tuberculin test. Third point, inconclusive X-ray. And the fourth and important point, cough for 18 days. Now, based on this particular, should we consider this one as a latent TB, or do you still in favor of active TB, because treatment modalities would be different based on the latent, based on the active? Because that particular word, history of cough for 18 days, has been mentioned, this particular line, I mean, if you remember, I mean, I think many of us are from the countries where tuberculosis is common. And there's a very famous thing: if there is a cough for more than 2 weeks, or more than 2 weeks, we'll always get checked for tuberculosis. All right. Or in Australian cases, you will find questions that immigrants, a recent immigrant, or someone recently been to a country, because these people are in Australia are not vaccinated with BCGs like we do. Right. Now, history of cough for 18 days definitely considered symptomatic case. And now what you do next? Are going to give like INH drug directly, or are you going to give or further doing sputum testing at this point? Okay, so these 2 points will keep you a little confused actually. Should I go for INH, which is a treatment for latent TB, or should I do more testing considering this is active TB? We'll go for actually sputum testing, because cough for more than 2 weeks is considered symptomatic. So these are symptomatic case. So this is a symptomatic case, and symptomatic case always consider testing for sputum. I hope that's clear. Great. Okay. So here is a test, like a sensitivity test. I'll just show you the calculation. We're not going for a details calculation. We'll do upgrade you with a biostat video to check upon. That would be helpful for you. Now, considering this one, what do you think? Any idea? Any guesses? All right. Now, in this one, it's a 80%, and we are using this formula here. We're using this formula here, sensitivity, but we'll do update a biostat video for you. I mean, when you look into this biostat video, it's kind of very boring. So these formulas you just have to remember. So to calculate sensitivity, TP by TP plus FN. That's the thing. So which one is TP? This 80, say it like 80, 80 plus 20. That's the FN. All right. Great. I hope that's clear with the 80%. I hope that's clear with the 80% results. Great, great. A little bit more. Try to add a little mnemonic. That's okay. 22-year soccer player reports a pop in the knee uh, during twisting, followed by a swelling, which test confirmed anterior cruciate ligament injury. It's not a difficult one. This question can be tested in multiple ways. Please look into this question, the test which will confirm. This is kind of like the initial, like anterior cruciate ligament injury, anterior to test, posterior cruciate ligament injury, posterior to test. These are early test, but more diagnostic test is a Latchman test. More diagnostic test is a Latchman test. I mentioned something. This particular question, we have seen this time in this way, but previously speaking, this particular question has tested in so many multiple ways. Um, I would like to add a little bit because this is a super high yield topic. Do you want me to explain this one a little bit more? Because ACL versus this meniscus thing, on and off, I think 50% of you get, a topic from this particular section. So let us just clarify one time. Now, I'd like to start with a, short story. If anyone from my 5 months course probably has heard this one, I of course, we all have neighbors. So do I. So one day I was called by my neighbor because they went for certainly walking. And I was called, I was at room, I was preparing for class, but they said it's an emergency. So I just went look into the parts and I found the knee has been swollen. So I took history and he said he went for walking. I said, after that, what happened? Did you fall down? I said, no, I mean, I was trying to do some twisting type of movement. So there was some sort of twisting movement and kind of, we can use that one, awkward landing. Have you noticed some people like just don't walk like that? Some people also walk like dancing like that. Some people also try to make back walking. Yeah. So those are only into walking. So they try to do variation, everything with walking, right? So sometimes awkward thing can happen. And eventually he has this thing. And if you check his areas, he has kind of like a medial joint line pain actually at the same time. And if I look into the his swelling and hematoses, probably it was hematoses because I saw little swelling, and at the same time there was a lot of pain. So I just told him and referred him to the bigger hospital. You probably need more tests like arthroscopy, MRIs, these things, my dear. And do let me know if I can help later. So I came back, but that's not the end of the story. 2 days back, or 3 days, I don't remember, 2 days back, and again I was called. Now I see serious situation. Now it's much bigger, full of swelling. Now it's very clearly visible, it's hemarthrosis. And at the same time, the pain increased like 5 times actually. Now tell me the diagnosis was it a meniscus or was it a ACL injury? Later, I mean, he was referred immediately. He was taken to the hospital, and they do the arthroscopy, and they went for definitely surgery. So I think some of you will think this is ACL, some of you think this is meniscus. Actually, the final diagnosis after arthroscopy, it was a meniscus. Now they had to go through the surgery. Bucket handle tear was very clear cut, and it was a meniscus injury. Now, why it is not ACL injury? Now, if it would have been ACL injury, in the beginning, it would have been more acute, more serious pain, like much more pain, much more swelling in the beginning. And it will not be like some sort of awkward landing, awkward twisting. Yes, there will be also like very vigorous something has happened, more dangerous thing, like someone went to play football and he was tackled badly, something like this. All right. So those goes more like or like very violently fall down. Okay, so that goes more with the anterior cruciate ligament injury, often like a motor vehicle, often like a football playing, something like this. And immediately more pain, more swelling. Okay, that one line will help you definitely. Is it clear to everyone? And of course, we do have another point like a joint line examination, right? There was words like joint line examination was more important. Great. All right. So ACL, you can see, is more like immediate swelling, and in this case, pain along the joint line more and gradual swelling. So in meniscus injury, I can say gradual swelling, or in ACL, I can say immediate swelling, rapid onset, and they cannot really walk actually. And even after I refer on the day one, they were like moving for 2 more days actually. Okay. So even whatever it is, I mean, MRIs and this that needed, and for further later we need Latchman actually for further. Right. So both cases probably we might need. This is immediately, you need to reconstruct ACL, and in this case, immediately some. Um, it depends on the injury level. I mean, initially rest, ice, this, that, and eventually you might need surgery. If eventually, if the meniscus injury is not minor, if it's major or it's a conservative thing, then definitely you need further surgeries actually. Okay, I hope that's clear to all the doctors actually. Right? Can you make a diagnosis next time, guys? If this question comes as a diagnostic question, can you make a diagnosis immediately next time? Right? I hope it is. Okay, please respond as a yes so that you can move to the next slide. Okay, moving to the next one. So ACL, you can see ACL cases, Lashman, PCL, posterior drawer, or even anterior drawer in case of ACL, and in meniscus cases, McMorris. Right? Anterior drawer is like a opening a drawer like this. Anterior drawer is posterior drawer like is you put it back like that. Yes, and another one is a McMorris test. In YouTube, there's so many nice videos available. By the way, guys, you can just type. It's good to know because in MC Part 2, you have to perform this test. Okay, so it's better to see at least this test at this point, actually. Great. All right, here's few more lines are given. You can check it later, but I think the main theme point I have mentioned already. I hope that's a 55-year-old presents to the exertional breathlessness, ECG showing tall R waves, V1, V3, respiratory resolution normal. What is the next step in the investigation? And now this can be one of the main line. Any idea? Any cases, dear doctors? Furthermore, we want to go with more. Is it a troponin? So didn't really mention much about the chest pain. Then we will thought about the troponin more actually. But exertional breathlessness, what is coming in your mind first? Exertional breathlessness, and also there is a little ECG finding. Okay. So in that particular case, so unexplained right ventricular hypertrophism. So always echo before going for a invasive test actually. All right. I hope that's clear to all the doctor actually. So our keyword is a exertional breathlessness and some positive ECG finding. It is indicating towards heart failure. Yes. So for heart failure, we definitely need echo. If you have our SMA note, I recommend you go to the medicine section and then you go to the medicine, then cardio. You find this heart failure related note. Have a look on that. Okay, take a note the heart failure SMA note for revision for the exam. Since it has been tested, there are very high chances in your November exam or February exam, it will be tested. Yes. So this ECG finding particularly is a big indication. Tall R may indicate right ventricular hypertrophy more actually. Okay. Ready for next one? Teacher reports a 5-year boy who avoids social interaction. Not really good line. And lines up the toys repeatedly. So there is a repetition. We often use the term stereotype movement. Please take a note on that one. Stereotype movement means repetitive type one, most likely diagnosis. Now, I can see most of you, it's a easy peasy diagnosis. This is autism spectrum disorder. Autism spectrum disorder, actually. Right. So repetitive play, poor social skill, it's like a, yeah, autism spectrum disorder. No such confusion. Here's something about the early, I would say, some early features of autism, as you can see. Yeah, lack of social interaction, even from the close ones, delayed speech development, spinning, object too much, um, playing alone, or organizing things. Or even if you are asking him for food and this, that, they get angry if this blocks and this, that were not organized. Okay. And some of the previous ones like social interaction and repetitive and stereotype things. Now, speaking about autism spectrum, if you go to our SMA note, you'll find there is a thing called psychiatry full note actually. Plus, you'll see also there is another thing, psychotherapy note, separately another one. Actually, both of them are very important to read, by the way. Now, coming to the autism spectrum, when you tell spectrum means it consists of multiple things, three. So under autism spectrum, number one is autism, where we say this lack of interaction. These things are common for all of them. So these two things, one is a verbal and another is a non-verbal. In autism, both verbal means single speaking. Of course, it will get delayed. They cannot speak as like the normal. So verbal affected. Now, what do you mean by non-verbal? Means like if you hug a small kid, they feel happy. Um, like hugging, kissing a small kid, they feel good. All right. Um, so these particular things they started to reject it actually. So rejecting this kissing, hugging, cuddling to small kids actually. All right. So verbal, non-verbal, both are affected here. Now is another one condition rates, which is common in female kids. Okay, and there will be stereotype repetitive movements actually. The small goes with the rates in the common for more for the school going kids actually. Anyways, here as well, verbal plus non-verbal, you are expecting this thing will be affected. But one exception, we might see in cases of Asperger's, and there is a very famous TV series. If you have seen the Good Doctor, has anyone seen this one yet? It's like the thing is called the Doctor. Sean Murphy. I'm not sure you have seen that one or not. So in that case, if you see his uh, verbal is um, kind of fine, but his non-verbal, like someone's trying to hug him and this, that may not be. So that's the one condition where is only non-verbal affected, but verbally fine, and they can be even genius. They can be very good in terms of their studies actually. So that's the Asperger's. That's the Asperger's. So, if anyone haven't seen, please check the trailer. It's available in YouTube. Dr. Sean Murphy. It's very interesting. Okay, Asperger's. And by the way, guys, I highly recommend to see any drama series for the doctors like Grey's Anatomy, then there's The Good Doctor, New Amsterdam. There's a lot of. They are helpful in some way, not for learning. It's more for, so how they are communicating actually. And of course, we all need entertainment. So sometimes if it be a little bit useful for us. So it's nice actually. Sometimes you see some words they're using. Example, like we use the term, I want to prescribe some test, I want to do some test. But in those series, that means the communication is as per those country doctors. those country people like say and to run some test. All right. So some of them are kind of like that can be helpful. All right. One more thing, doctors, when we read the question, then you start answering. All right. I mean, we don't appreciate over smarting. Just like make sure, when I read that question, immediately after that, you start answering. Right. No need to overstep. Okay. 8 years boy diagnosed with ADHD. What is the first line pharmacological treatment? All right. Original question would be a bit more longer. So they mention ADHD, but in the main exam they will say hyperactivity, not listening to anyone. His age is like 7 or 8. He started to going to the school, and and he his stubborn, actually, kind of like this. All right. So it's more going with the ADHD. It's going more with the ADHD. In my psychiatry lecture with my 5 months doctors, we discussed something. Normally, ADHD, as the time progresses, it's become like conduct disorder. Chances are high. All right. And when they become a little bit more bigger, with the time, like more than 18. In that particular time, there's another one came up. We call it antisocial. Antisocial. Now, let's add some time frame 5 to like 11, like then 12 to 18, and this one like more than 18. Please note in psychiatry, the time frames are really, really important. In psychiatry, time frames are really important because we look into the question and based on the age, we can also make some diagnoses because there will be a lot of close call between two answers often. Between two answers, we get confused often actually. So that this age related differentiating things would be helpful. We'll see in another question where age is very helpful, which is the child with limb can be extremely helpful. Now coming to this one as the first line of the management, and we're thinking about the methylphenidate. 8 years, we think more about the methylphenidate. Few things I have taken. This John Murtak has very less amount of psychiatry, but likely this thing is given because this is more like pediatric as well. That's why it's available. But the typical psychiatry is very less given in John Murtak. That's why you need to follow the SMN note for that particular. Okay, so among the medication, they will be mentioned that okay, methylphenidate, but there is another one, dexamphetamine. Okay, now there was previous question speaking about the previous things in AMC. Um, we also have seen in between these two drugs, often our doctors get confused in terms of. So you can see one thing that which one is recommended actually, yeah, more recommended actually. So you can see it's like dexamphetamine is more preferred in older children since our age group is more younger. So I think we prefer more with the phenidate, methylphenidate. Before the age of 6, um, yeah, so some information given as well. Here is another thing. This particular one, dexamphetamine is use is less common than the methylphenidate actually, right? So it's a close call between methylphenidate and dexamphetamine, even though the another one is not mentioned, but you will definitely keep getting this particular question, methylphenidate versus the dexamphetamine. All right. Sometimes, Ricola made their own things and this, that. So a lot of things can be there. So um, we have to be careful in terms of that. And let's say this one is more chances of coming in the main exam. So often this is a clear-cut question, but some cases I have seen in past, they also add that dexamphetamine, then that becomes very difficult to answer because both are correct technically. It's just methylphenidate is a bit more popular. Okay. So recap from a previous year how it was tested. One of the question regarding the ADHD, boy the ADHD initially treated with methylphenidate. See, methylphenidate has been popular. After 6 months, how do you adjust the dose of treatment? So you can see the dose adjustment, overactivity. These things are also important regarding the exam. So it's not only just reading the drug, but the drug side effects, drugs overactivity, and when to reduce any particular drug for major diseases is very, very important learning objective for AMC. Guys, I want your little response. Please mention which one is your answer here. So definitely the answer is going to assess the level of, because hyperactivity is one of the key feature. Hyperactivity is one of the key feature of these ADHD kids. All right. Here's a special line I like to add. So these are stimulants, methylphenidate, dexamphetamine. These both are first line. It's just the methylphenidate a little bit more used. What about some doctors might be thinking about, doctor, what about risperidone? That's also used for severe aggression. In ADHD, there can be aggression too, but risperidone is used for the aggression in autism, not in the ADHD cases. This is interesting. Next one. 50-year-old, always check the age group. 50-year man, sex is important. And severe epigastric pain radiating towards the most specific diagnostic test here, please. I think this is one of the question which has been tested in July as well. Now we can see a July question is coming into August, right, guys? Did you notice this question was um, present in July? Anyone remembers? Yeah. So see, you know, often immediate 1 to 3 months question was is very important. So in this particular case, what we're going through was diagnostic landscapes. Yes. Amylase is non-specific, so it's lipase. Okay, so after lipase, we do ultrasound. After lipase, further we go for doing ultrasound actually. So diagnosis clinical plus lipase, like 3x more than the normal, 3 times more than the normal actually. Great. Uh, Speaking about pancreatitis is a part of abdominal pain. So abdominal pain related cases are very, very important. As like the chest pain cases are very important. One abdominal case is absolutely important for the exam. Great. In case of pancreatic pain, there will be epigastric pain and directly radiating towards the back. On the top, the patient will also have nausea, vomiting, and abdominal pain features. And of course, more problem with the fatty food and this, that, definitely. And patient's vital can be deteriorating. Okay. There is a special criteria for to see the severity of pancreatitis. Anyone knows about that particular criteria? Is a one particular criteria. Yes, that's a Ranson's criteria. You can Google it or find it in the Davidson's Ranson's criteria for pancreatitis. And you can also read the causes of pancreatitis from Davidson or any books actually, like can be idiopathy, gallstone, ERCP procedure, drugs, many, I mean, there's like a 10, 11 causes that can lead to pancreatitis. Okay, or even traumatic, even traumatic. Good. Okay. So pancreas questions are coming, and there'll be another pancreas question, I think, by the end of the slide, actually. So pancreatic things have been tested, actually. Don't forget to read also about the pancreatic disease. I think in our second question, I think we will also discuss a little bit about the pancreatic disease. So stay with us till the end. The patient with rheumatoid arthritis affecting small joints and knee joints as well on NSAIDs and but inadequate control. What is the next step in this case? Okay, because it is rheumatoid arthritis, the bottom line treatment for rheumatoid arthritis is this particular thing, DMAR, DMARs, right? And yeah, so in that particular case, um, I think we prefer giving the methotrexate. Among the methotrexate is one of the choices. Methotrexate is the choices. If not methotrexate, can you name one more? If not methotrexate, can you name one more that can be really useful? Answer: it can be sulfasalazine. It can be sulfasalazine. Okay. So demand is for the persistent active. Yes. Okay. Let me add something in this particular slide. Be helpful for all of us. Like to add two things. I hope you remember this slide if you have seen it before from a book, Davidson. And there is a special another line we like to add is so please don't forget to read our um, rheumatoid arthritis note. Don't forget to read, rheumatoid arthritis note actually. I'm sure we all are familiar with um, rheumatoid arthritis things. Very, very important. Okay. By the way, these slides are also available in that particular note thing. But we're speaking a little bit about the DMARDs. So let's just discuss. Do you want me to little discuss about it, or are you already familiar with DMARDs? So these two are some of the most important drugs. Okay, I think looks like you guys are familiar. So please make sure you know some of these side effects. Uh, Liver related this hepatitis or jaundice, this side effects is universally kind of common. And one of the unique things you need to remember for methotrexate, like bone marrow, that can be affected. As I said, liver one is universal for all of them. Then this sulfasalazine can lead to um, neutropenia, all right? Other than the liver problem, hydroxychloroquine is related to eye problem, right? Like retinopathy, yes. Then some of the others may not be much needed. Then this cyclosporine, this thing can lead to renal problem. Cyclosporine can lead to renal. So you need to follow up with the kidney tests actually. Okay, so some of them, if you remember in that way, would be really helpful. Also, this question can be also tested in that way, like which of the particular DMARDs, disease-modifying anti-rheumatic drugs, are safe in pregnancy. So sulfasalazine, hydroxy, and azathioprine, these are considered safe, but methotrexate is definitely leading from the because it affects the neural tube. Lefunamide, cyclophosphamide, gold penicillin, these are unsafe during the pregnancy. This particular thing is really important. This is already available in SMA note, and in the SMA note, you will also see uh, in rheumatology, like medicine and rheumatology, very important to look into that osteoarthritis, rheumatoid arthritis, gouty arthritis, this particular X-ray findings actually, right? Looks like you guys are familiar, good to go for the next one. 34-year male with rheumatoid arthritis on sulfasalazine and azathioprine plans to conceive. What is the best advice? Yes, please, guys. This is also important that rheumatoid arthritis and um, conceiving. So, male with sulfasalazine plans to conceive. Should he continue with this particular drug, sulfasalazine? The answer is I don't think so. Continue both. No. Like to add this one. So stop the sulfasalazine. It is very important to stop the sulfasalazine if they're trying to conceive. Why? Because the sulfasalazine thing, okay, this can lead to azoospermia. So can't conceive is another important thing for rheumatoid arthritis. So choice of drug in pregnancy is also very, very important. So choice of drug in pregnancy is also very, very important. Even male with rheumatoid arthritis with sulfasalazine, there can be issues. I hope that's clear to dear doctors. Next, 20-year woman with a history of unprovoked DVT. Now, this is a question. It will change surgical question. DVT 2 years ago. Now, requesting contraception. Because when someone has a DVT, usually recommended not to take for some time the oral contraceptive pill, but it's people's choice. Um, if they don't like barriers, of course, they will be requesting for contraception or pills. She's not on any anticoagulation um, like on not on warfarin type of drugs, which is the most appropriate choice in this case. So I think it's better we go for progesterone pill, because the main thing we need to avoid the estrogen. The main thing is we need to avoid the estrogen. All right. If you are asked this thing, what is the best advice? Because here the person is requesting a contraception or like a pill. So hence you need to give a pill to that particular person. Another thing like best advice can be barrier, but that's if the person comes for the advice. So you will get to see these two types of question. Okay, so you get to see two types of question, and okay, in the exam, asking for pill or whatever. In that case, recommend asking for advice. Now it can be pill, it can be barrier. In that case, the answer would be barrier. Is that clear to everyone? Okay. 15-year-old girl with the 7 weeks of pregnant. She lives with her parents and ask you not to tell them. She requests termination of pregnancy. What is the most appropriate next step? All right. So of course, if someone get pregnant and she lives with parents, then we can add this point that she is a minor. So main one of the considering point would be um, she is a minor. Okay, everyone agreed on that point. So since she is a uh, so should we go for C first or refer to gynecology for abortion assessment? So she is currently under the parents' custody. She's a minor. She's not living with a boyfriend. The question is the Gillick competency is applicable here or not? She expressed wishes, of course, but it's a complicated thing, definitely. So I think best answer is definitely encourage her to tell her parents. That would be a better answer. So encourage her to tell her parents first, actually. Okay, let me tell you about and clarify some of the confusions, actually. Taking a second. Do you have confusion regarding the Gaelic competencies, guys? Or should we move forward, actually? This one answer is surely encourage her to tell her parents first. Let me know if you want me to discuss the Gaelic competency or do you have confusion regarding the Gaelic competencies? All right. Now, some of the things, please understand some of you guys, like these particular things we already regularly discuss in our 5 months course. But if you see every topic, if we are going through and you don't know those particular things, yeah. So yeah, this one is definitely a discussion topic. But previously things like DMARDs, so this kind of topic you should be familiar by this time. If you are continuing with the recall course and if you're considering that you are having an exam coming up shortly, all right? Guys, please check if anyone's video and things are on. Please turn it off in that particular setting. And someone is coming with a mobile, I think. Yeah. So please make sure use the laptop. That's how we can avoid this kind of problem. Okay. Let's focus. Let's take a little bit time on this click thing. Okay. First of all, anyone anyone who is under 18 is a minor. Everyone agreed on that point? So parents should be involved. Okay, so this is the basic, but there are some exceptions, right? What are the exceptions? Like um, choosing a right contraception, right? So choosing a right contraception. Do you want to involve the parents? Choosing the right contraception. Do you think is it important to inform the parents in this case? Particularly, it can be embarrassing. Sometimes can be embarrassing. Okay. So choosing a right contraception uh, with or without living with parents. No need to. inform. Yeah, no need to inform the parents. Is that clear? So this contraception choosing or relevant cases, they can go to a GP, and it's like you don't really need to inform. It's just a matter of contraception. Now coming to the important part, that is somehow got pregnant, and if it's a abortion, abortion in a pregnant. Let's listen to this part carefully. Um, Abortion in a pregnant, and let's say age 16 years, right? And this particular person living with parents. So what to do in that particular case? And of course, there will be a decision is coming. She'll be requesting not to tell her parents and just continue with the procedure. Okay, just give me the drug, I'll just take it and this, that. Now she's living with parents. She's under the parents' custody. Okay, I mean, thing will be tell her first to inform parents. So if unable, you take action. Clear now? So you take action by involving. I hope that's clear to our doctors. Now, another point, living with BF. These cases, living with boyfriend, and again, same thing, tell her or advise her to inform the parents if unable. Now the question is coming, do you like to take action? Answer is no action is required. Why? This patient is self-dependent. Is that clear, everyone? So in these cases, like 15-year or 16-year, these cases, you can follow this one. Is that clear, everyone? I try to break down as much as I can. So about this, Gillick competency. Clear, everyone? So I just try to break down as much as I can. All right. Okay, let me try to also save that part. Just take a second. All right, guys. Thank you for your patience. All good. Next one, interesting question, and a very popular one for the main exam. This time is a 60-year and possible dysphagia to solid and liquid and the weight loss. Okay, they have given a lot of options, clear, loud and clear view. Barium solo showing, barium solo that is showing uh, irregular narrowing of the distal is what is the most appropriate treatment. I think this is the most key point. I feel like barium solo showing long irregular narrowing in the distal region. So what it could be. Yeah, irregular narrowing. Actually, in which cases there is irregular narrowing? Actually, in cancer cases, there can be irregular narrowing. Some cases they mention a term filling defect. I mean, one part probably has someone has bitten the filling defect. Now, final answer in these cases is a esophageal, so surgery on the esophagus would be required. So esophageal surgery would be required in that particular case. So let me show you first. So progressive dysphagia to solid liquid, weight loss, irregular necessity, esophageal cancer, first of all. Not achalasia restriction in this case. If only dysphagia to solid and no weight loss, then you will think more about the stricture or something else. But at this point, because weight loss is involved in dysphagia to solid and liquid, so high chances this is esophageal cancer. Definitive treatment and most effective treatment is surgery. Surgery depends on the grading, staging, definitely. But wherever possible, esophagectomy, this surgery is more important. So from the John Murtha, if you open the dysphagia chapter, please do open um, the dysphagia chapter and check the red flag related to dysphagia are very, very important. Red flag related to dysphagia are very, very important. Now, speaking about dysphagia, that dysphagia to liquid achalasia, dysphagia to solid esophageal cancer or stricture, again, dysphagia to possibly um, motility disorder. Some of the motility disorder, there can be dysphagia to liquid or dysphagia to liquid solid, both together actually. Okay, because dysphagia to liquid initially patient may not understand. So scleroderma, myasthenia gravis, some of these cases there can be dysphagia to liquid as well. And there can be like based on the barium, like esophageal spasm, there will be like a heart attack like feature in esophageal spasm, nutcracker esophagus. There can be heart attack like features would be um, there actually. Right. Now, anyways, there is like uh, we have discussed in some of the live classes dysphagia, dysphagia to solid, dysphagia to liquid. So some of them we just have added here. Maybe you can have a look on that one. Uh, Achalasia, as you can see. Usually in achalasia, there is absent in the mindtrick plexus, and in mindtrick plexus is responsible for peristaltic movement. That's why in achalasia cases, there is lack of peristaltic movement. Dysphagia to liquid problem is noticed initially, right? So this is interesting, right? And the management related to achalasia will be also very, very important. Now, a very quick question. Are you expecting a narrow end of the esophagus in achalasia or a lax area or relaxed area in achalasia? The answer is in these particular cases, a narrow esophagus like this one, a rat tail esophagus is suspected. So when you have a rat tail thing, you need to make it dilate. So you can try drug, you can try dilator, often known as Heller's dilator, and the ultimate thing could be surgery. And the most effective thing is also surgery at the same time. For achalasia, what we do, achalasia also tested this particular year. So initial test is barium. Understand one thing, barium is the initial test for all esophageal condition. Then some of the specific tests like manometry. Manometry is a specific test for the achalasia. And for the ZERT, barium is initial probably, and 24-hour pH monitoring, and those patients will be associated with heartburn. In achalasia, there will not be any heartburn, right? Keep it in mind. All right. Difficulty swallowing, some cases chest pain, this can be the features. All right. You see, barium cases, even cancer cases, barium can be even initial test actually. right? Eventually, you need to do biopsy, and furthermore, you need to go for the surgeries. 95% esophageal cancers are squamous cell carcinoma, generally. All right. So, worldwide, it's squamous cell carcinoma. Interesting point. But there is a popular question in AMC. In Australia, which one is popular cancer? In Australia, which one is popular cancer? In Australia, I mean, the type of popular esophageal cancer is adenocarcinoma, actually. This is, again, has been tested in the exam. All right. Next question. 22-year man presents with a hematuria 2 days after upper respiratory infection. He has normal blood pressure and renal function. What is the likely diagnosis? I think a similar question we have seen in July, and also we can see same is kidney related, kind of similar related a question from this particular area. So presence with hematuria. I think nephrotic syndrome. I think in July, and in August that's like AGN looks like. So presence with hematuria 2 days after a upper respiratory tract infection. Okay. So we are going in the right way. Normal blood pressure, even though and renal function is also normal. What is the likely diagnosis? So can we apply something we call rule of two? Yes, certainly we do. So we call it as IgA nephropathy. We call it as a IgA nephropathy. Rule of two, what is it? They will be giving you AGN scenario. AGN scenario. So 2 days, if there is a sore throat, both of these cases, AGN, acute glomerulonephritis, itis, so there will be a source of infection. So often comes as a sore throat. So if it is happening 2 days after sore throat, then IgA nephropathy. If it is happening 2 weeks, I mean sore throat, 2 weeks, then PSGN. Very popular in the exam. Previously tested, now again tested. I mean, couple of year. I mean, I have seen this thing coming. Okay, everyone clear? So that's the rule of two things you need to remember. That's the rule of two things you want need to remember. By the way, in the SMA notes section, our renal notes, yes, are important. Even though given hypertension, I mean, we couldn't find it, but hematuria 2 days after respiratory infection and suspected. I think likely cases, this hypertension thing would be there, and kidney function will be showing proteinuria. That is also expected actually. Even if you go by exclusion method, I think maybe the question has a little problem. Okay, I think the question needs a little modification. We are expecting some sort of proteinuria. Blood pressure can stay normal in some cases actually, but in AGN cases, we highly expected high blood pressure and some protein in the urine, and RBC or RBC cast in the urine is highly appreciated actually. Okay. Some cases, we just like to readjust based on the questions or thinking that Ricola may have made some mistakes actually. Great. All right. Okay. After this question, we'll go for a break. 25-year-old father died of colorectal cancer at the age of 60. Her mother has a history of fibroadenoma. She's asymptomatic. What is the most appropriate advice in this case? Father, family history of colon cancer. Okay, is it A or is it B? Like self mammography, okay, out like self breast, okay, gone. So mammography will go into colon is like colon and breast. That's like two of the most important screening. because there is a family history. So first degree relative with colon diagnosed. It's a first degree. We have to check is it a first degree or not. First of all, father died. So of course, first degree relative, first degree colon cancer. Um, so screening will start a little bit more early. That's like latest RACGP. Okay, cell-break examination not recommended as per the journal. Yes. All right. So a little early because first degree relative has been involved. Clear, everyone? Because first degree relative has been involved. So um, I will double check the reference yet. If good question, second degree relative, then our answer would be B. I mean, one primary first degree relative, this is very big thing. Okay, that's why a bit more early. Great. I think would like to add a screening program session somewhere in this batch will be important. Yes, age of the relative also plays important part. If this is below the age of the 50, then even they are high risk group. Yeah. If first degree family member died before the age of you know 50, then they become like a high risk group. Okay. So highly recommended you go to RACGP or open the Google, type RACGP colon cancer screening. So that will take you to that particular screening related to RACGP. Please check it today. Otherwise, you will forget actually. Great. So we'll open an inquiry zone about the class. So our second class, if you have any inquiry, so feel free to ask me any inquiry about today's. All right. Maybe this particular question you can copy and paste. I mean, the last one about the colon cancer, or someone can request me in that inquiry zone to brief a little bit more about the colon cancer. Actually, I'll be happy to help with the reference. Okay. Okay, let's take a break, guys. I mean, after we come back, there'll be interesting question coming up regarding the linking. Okay, great, guys. You guys are wonderful, doing well. When we come back, we'll do this question. Thank you, guys. From next classes, we'll be speeding up a little bit because a lot of doctors are new today. Orientations are ongoing, still admissions are ongoing, and usually we try to cover 40 to 45, some cases 50. But because being a lot of doctors are new, we are just going through smaller and also talking something additional. I'll also try to brief something about the system. Will you be in like a uh, interested in knowing about like a few things about what to do after MC part one? Maybe I can also add a little bit in 5-10 minutes after the session, I think. Yes. Doctor, I think it will be better if you add that one in the inquiry zone of our Facebook group, not in the Zoom actually. All right. So we'll be happy to help. So just add that one and just write your inquiry. I'll be definitely add a reference. Yes. Thank you so much.
Yeah.
Okay, everyone, let's get started. If anyone has joined late, we are currently going through this recall course and already started. And it will be absolutely great if you have exam in October, November, or in February. And this is our, the details and the routine. And also exam supports are included. I think a lot numbers are November, but even if you have October exam, there's classes during October and also September and also, yeah. So this is the thing, the course till date a big number has passed. So I'm sure many of you will be also doing well, definitely. And we started on 15th and it will continue till 30th of October. And also there will be classes on November at the same time. Great. I think let's go without any further delay and then continue from where we're going through. Recap. This was the question. I asked you a little bit add in our inquiry zone. We'll be definitely discussing about colon cancer screening more, shortly. I mean, in some the next lecture, we bring something special for you about the colon cancer. Actually, there's multiple things to talk about regarding the colon cancer. Okay. Moving forward to our next question. 8 years, 8 years boy has sore throat or upper respiratory infection. Many way they can present it. A week back, now with a limp. Okay, now the person coming with a limp, with you can see the right hip pain, no trauma, X-ray is normal. This is very important for a limping kid to check on the X-ray because some of the findings are related to X-ray, which is the most likely. Now, can it be Perthes disease? A quick question to start with. Can it be Perthes disease? Less likely because Perthes disease P for positive X-ray finding. Also, capital femoral epiphysis, there will be also X-ray finding. But in this particular cases, I think there won't be any, and there is a special history of upper respiratory tract infection. So this is going more towards, yes, going more towards the limping kid. Now you can see, um, I mentioned this thing earlier. The age is very important. Am I right, guys? So we have 4 or 5 conditions here, 5 conditions. And there are certain age groups like developmental dysplasia of the hip, small kid, um, just born, parents are happy, and maybe after 7 days the baby is ready to go home, or maybe after 2 3 days. But the pediatrician is trying to do some examination, and they bring a bad news that probably you need to stay a little bit, or the special attention the baby is needed because the kid is having developmental dysplasia of the hip. The parents will ask, "How do you understood this is DDH?" So, okay, we perform this like abduction of the leg by specific two of the maneuver. It is called Ottolarnis and the Barlow's test, right? You heard about this name, I'm sure. So they just try to abduct the legs, like just putting both legs apart, and there will be clunk or additional sound. So that is indicating this is developmental dysplasia of the hip. 4 to 8 years of age group, these particular conditions are common, transient and the Perthes. It is also possible sleep capital femoral epiphysis. It is a little bit more, and we say of an adolescent group. That is the sleep capital femoral epiphysis. They also do have a positive finding, but this disease also have positive finding. Special term P for positive X-ray. Exactly given in MC exam, increased density of the femoral head. There's a line of an given increase density of the femoral head. This is how a specific line was given in one of the exam. right? And sleep capital femoral epiphysis. Often we compare ice cream is coming out of its cone. Okay, so the X-rays more looks like this, like because the ball is coming out from the socket. That is sleep capital, and anytime, any age group, this can happen. Associated with fever, unilateral joint pain, fever, okay, inner joint pain and fever, and it is often swollen. This is suspected septic arthritis until proven otherwise. Very dangerous. Without any further delay, you need to do arthroscopy, and immediately after that, you need to give an IV fluid clots to save that particular joint. Right? Is it clear a bit, guys, like why age groups are important? By seeing the age group and one, two unique features, you are able to make the diagnoses. Great. Very, very important, guys. Also check the Chanmutta for the managements of TDH, management of Barthes, management of SCFE are also important. Great. Like in DDH cases, there is pelvic harness are given. Pelvic harnesses are given. Okay. Will we discuss post-viral limb, normal X-ray, transient synovitis? If you remember up to this, it is more than enough. Okay. Next question coming up. 9-year boy falls from while playing, injures the elbow and numbness on the left thumb. Please monitor where is the injury and where it has been extended. The X-ray shows supracondylar fracture. By the way, some cases they may not tell you supracondylar fracture, but rather they will give you a finding in that case. Now, what to do next in this case? So we definitely need the, I think, X-ray to comment honestly, right? But let's just think it's not the most serious one. It's a grade 1 or something. It is possible still to go with closed reduction in that case. Supracondylar fracture and some nerve syndrome. Yeah. So we need to like solve that particular problem by do a quick reduction. By doing a quick reduction. As I said, we probably need that original X-ray to comment on that, what is the degree and that level of the fracture. But initially, it is very important to rule out actually. Yeah. Okay. Let's just see about the degrees. Then I think our concept will be a little bit more clear actually. Okay. This reference, yes, this reference, and this is a reference of supracondylar fracture. Okay, type 1 displaced, type 1 angulated displaced, but both got is intact. That's why I mentioned we might need the X-ray. Type 3 is a complete displacement. Type 4 is, as you can see, yes, it is. So displaced type 3, type 3, orthopedic emergency, especially if complicated with an absent distal pulse. Okay, I'll let you check this reference for a while. I'll give you a minute, guys. Please check it. Then we'll enter into this. Okay. So everyone, so coming back, so as you can see, displaced supracondylar type 3 type 4 as being an orthopedic emergency actually, especially if complicated with an absent distal pulse. So mainstay is do not delay in those particular cases. So it's very important to assess the neurovascular status and all these things. Understand one thing, most of these fractures will be extension type. Let's review this one again. This question, is it closed reduction or is it, I think we do have a little less information because of not having the x-ray. Let's just try to fall down playing injuries to elbow. Okay, only information mention numbness in the left thumb. So if neurovascular compromise, usually we mention it might need, you know, yeah, I think we should try the closed reduction, uh, then check whether the numbness has gone or not. If not working, then go for open reduction. What do you think, guys? But it's still depending on the, uh, I think the X-ray finding. Okay, I do have another reference regarding that. So there can be operative and non-operative cases actually. So here is an option: close reduction and percutaneous spinning procedure actually, especially type 2 and type 3 supracondylar fractures. Okay. Time to CPP indicated by deleted by neurovascular status. One can be non-urgent, can wait overnight. Okay, and one urgent, you can't wait overnight. So there's certain points can be like this. Yes. So I recommend you to check a little bit from the ortho bullet um, regarding this actually. So I think it's a possibility we might need the pinning thing, but like close reduction plus the percutaneous pinning. What I understood from this question. What do you think, guys? Yes. But as I said, you all can understand we need that exact X-ray to comment on this question actually. Yes. All right. Okay. 7-year boy fall down from his bicycle. X-ray confirmed non-displaced supracondylar fracture of the humerus. So, what do you think? I think this one is easy so far, so good. For this question, I think in this case, A would be the right. Fracture like Colles fracture, scaphoid fracture required below elbow plaster cast, whereas supracondylar fracture, this that thing, required above elbow cast actually. Good. So recently, we see supracondylar fracture things coming into the exam. Other than this, there's certain other things are very important from the orthopedics. Please make sure we all need to read them very well. Okay. Next one, 37 with pregnant woman, blood group O negative, and is like assaulted. And what is the most appropriate next step? Keep going, guys. Giving you a few seconds to think about it. So, since there was a traumatic incidence, so there's a possibility of woman who is having O negative blood group. Yeah, so there is a possibility of admixture, of this positive and the negative. So that's the reason in this particular reason, administration of anti-D will be very, very important. So Rh negative plus trauma anti-D regardless the gestational age. That is the key line here. All right. Great, guys. Okay. The same line, we mentioned in the question. It's given here. If there is a fetal distress, then we can consider furthermore like situations like C-sections. But anyways, it's not a huge difficult question. Next one. 35-year-old woman presents to the ED with bruises saying, do not send me to home, he will beat me again. So what is the most appropriate step? Say a woman who comes to the ED emergency department with bruises. So what you need to do in this particular case, if this possibility of any assault case, call police for her safety is number one. Like if she's in the hospital, definitely you can call the police. Of course, you are not like you can ask the staffs to call the police for the safety. So D is the appropriate answer. It's a medical ethics question. Yes. Why would we advise her to call police? So domestic violence safety comes first. We call the police because it's in the emergency department. All right. Very easy one. Last one. The patient on rosuvastatin has a difficulty in combing hair. CK and ESR are normal. All right. So, what is the most likely diagnosis? What is the most likely diagnosis? Okay, we do have a few points. Very, very important. I like to add something which is called, proximal muscle myopathy, an important term. Proximal muscle myopathy. Okay. Some example of proximal muscle myopathy. This can happen even in kids cases. Also, if you have remembered Duchenne muscular dystrophy, there are like a sign like Gower sign. Kids they get up by climbing their own feet, and that is known as Gower sign, Gower maneuver. The same problem exists. They have, some uh, problem in myopathy and this that thing. Just give me a second. All right, sorry about it, guys. So back. Okay, proximal muscle myopathy. So example of some of the proximal muscle myopathy would be, combing the hair. Can you give me more examples? So one is the combing, then buttoning or unbuttoning the upper button of the shirt. You wash something cloth and you put it in a hanger. All right, you raise your hands. You get up from a chair. These all are example of proximal muscle myopathies, right? And in kids' cases, just getting up from sitting, that's also the proximal muscle is in use. Now, based on the lab, there is a possibility of making diagnosis, as you all can see in this question. Our final diagnosis is statin-induced myopathy. The question remaining here, why? Because ESR and the CK both are okay and normal here. Now, how I'm telling this particular thing, drug induced, like it can be statin. In our case, there is a drug mentioned like a rosuvastatin, which is a statin group of drug, where ESR and CK both expected normal. Some cases definitely ESR CK raised, which is polymyositis, also known as like dermatomyositis, almost same thing. Either of them will be given in the question. So ESR raised, CK raised, both are raised. Another option would be given in elderly, like a 65-year, pain all over the body, and trying to touch a shoulder, and you find only ESR is raised. Only ESR is raised. Right? So we'll follow this one universally for tackling. See, I mean, forget about hypothetical thing. AMC exam is about, few of the rules and some of the exact question. Our experience will share. Hypothetically, if you see like trials and this, that, there's a lot of thing and can happen in a lot of way, right? So for exam, you have to be focused actually. If you too much start adding your hypothetical thing, which is good for your own knowledge in terms of dealing complicated patient in future, but at this point your head has to be totally into um, focusing on the exam, because you get only like 1 minute and like a 20th second probably for solving one particular question in the exam, whereas ethical question will take much more time. So questions like this, in just 1 minute, you have to pick an answer. So those hypotheses and this, that will not work certainly. So here we go. This type of formula, I mean, we try to provide, but if you can make of your own, I mean, it would be even more useful. Okay. So here is we go. The drug-induced myositis, ESRCK normal. Poly means everything like spoil myositis, everything raised. Yes, sir. Seki always. Polymyalgia rheumatica, elderly lady trying to touch her shoulder. So this is only yes, sir. Raise, Seki normal. Is it clear, guys? I'm finding a little less interactions at the end. Okay. Because our battery goes down at the end. Okay. 16-year boy. Yeah, so bring some energy, guys. Yes. Okay. 16-year boy presents with gynecomastia. Yeah. Male breast enlargement. Right. And tall stature and small testes. So, what is the most likely diagnosis? Interesting question. Tall stature. So, any genetic issues with a tall stature, I mean, either Klinefelter or a Marfan. Marfan at the same time has other connective tissue problems. So, but this one is with gynecomastia is going more towards the Klinefelter 47 XXY, right? Klinefelter. And they do have, small testicles actually, tall, but at the same time, small testicles actually. Funny quote in funny way, don't take it in other way. Example, professional bodybuilders. There's a very funny quote and funny mystery. Professional bodybuilders, they also do have small testicles. Did you know this information? Professional bodybuilders, they do have small testicles. Now, how come this thing can happen? Okay, now because they took a lots of steroids, actually. I'm not talking about the natural bodybuilders. So using a lot of like, steroids, eventually you are blocking that receptor level of the, because if you see the steroid synthesis, there is like the testosterone production thing is, so when they're taking that particular steroid thing, the testosterone production at some point will be stopped actually. So testicles will be atrophied. Now that particular thing can be corrected by post, cycle therapies actually. Then again the testosterone production will start. But the problem is they don't do this thing under professional doctors' guidance actually, and professional doctors never recommend anabolic steroids. So the problem happens that if little bit here and there thing happens, so they could have this problem. So it's not universal, but those of the professional bodybuilders, they don't follow the protocol well. There's a higher possibility of testicle could get affected. So they make funny memes like that, even big body, but small balls, something like that. All right. So Klinefelter, as you can see, Klinefelter. Interestingly, elevated FSH LH, probably you can see as well. Here's few information about the Klinefelter, not only tall, but the small testicular size. Also like wide hip, narrow shoulder, looks, I mean, not proportionate, I would say. Okay. This particular year, we have also seen, when you were reading Klinefelter, you should know about the Turner. Turner also have tested there. I mean, last year. So in case of Turner, like, short stature, right? Short stature and female. And there's the thing called the wave neck neck. Then stegover is many other features. Now, there's an opposite to Turner syndrome, and that's also known as the Noonan syndrome, actually. So it's also called male Turner syndrome. Male Turner syndrome. And this has been also tested very recently. Male Turner syndrome. So you can see his face is not probably, with due respect, not looking exactly like others. Yeah. So short stature as like other Turner syndrome, and in some cases there can be pulmonary stenosis. So altogether, Noonan syndrome, genetic, things ruling out is important. Also, very important to rule out their cardiac status in case of Noonan syndrome. So cardiac status, vision, these particular things are very important ruling out. Good. So please take note. I mean, you will double check about Noonan syndrome actually. Okay, slide about the Klinefelter. Tall gynecologist multistable. We'll think about the lining. Okay, this will help 55-year-old with a intermittent dysphagia. Now, dysphagia can come in a lot of ways. Dysphagia means, unable to swallow. I mean, or difficulty in swallowing, both solid and liquid, along with episodic retrosternal. He has no weight loss or regurgitation. Okay. And barium solo is given. This is how it looks like. I'm giving you little time to interpret this one. All right, everyone. So let's get back with this one. Yes, you're absolutely right. This is esophageal, you know, spasm. It's more like a corkscrew appearance. It's more like that corkscrew appearance. Okay. Are you interested? I mean, seeing some barium pictures. Okay. Give me a Okay, everyone, let's get started with testing. Yes. Now, is this achalasia, is it looking that narrowing? Or is it more looking like a relax or lax at the end? See, achalasia will have a rat tail type of appearance. This one rather looks like more relaxed at the end. So more relaxed at the end, it can be a case of ZERT. What do you think? Sometimes cases like a ZERT, it can be like this, like the ZERT and this that. It's a possibility. So there's another thing called hiatus hernia. This most diagnosis is little difficult. Hiatus hernia. Okay. Now this one probably will help you more at the end. Now that is the classic rat tail. Okay. That's the classic rat tail. Now this one is a classic achalasia. This one is your classic achalasia. What do you think about this one? Again, rat tail, bird beak, whatever you say. Again, achalasia. This one is like someone has bitten the lower part, like a filling defect or the part is gone. So what do you think about this one? This one is a actually cancer. This one is actually a cancer, carcinoma. This is a wave. It usually never come in the exam, but for understanding or for future preparation, you can keep in mind like these are like a wave, kind of like a neck type of thing, like a wave. So pharyngeal wave. It's most cases like a bit congenital. Again, a filling defect, which is a carcinoma. Again, a filling defect, which is a carcinoma. Again, it's like a quite a thick, can be hiatus hernia. This is the classic and probably one of the most popular, other than the achalasia. This one is very popular in the exam, and this one is classic. The classic corkscrew. You should see more pictures in the Google or sometimes in the Radiopedia. Yeah, so classic corkscrew. This is, you know, uh, spasm of the esophagus. So if you see spasm, extreme hot or extreme cold, you need to avoid. Okay, extreme hot or extreme cold, we all need to avoid. Okay, so well done, guys. I mean, I thought you will make a lot of mistakes, but I'm glad that you guys were excellent. All right. Okay, it's a good test. Now, if it goes well, I mean, in next class, I'll give you a little demonstration on the radiology. We do have an album in video channel. I will show you, give you some demonstration. What exact radiologies you need to know for AMC. I'll give you some demonstration next time. So, cost related things treated with calcium channel vapor nitrate, and there's a part big appearance. It's like you need to do, you know, dilatation by Heller's dilator actually. And ultimate one would be some cases. What do you think? Yeah. Achalasia is like a narrow one. Achalasia would be narrow one. So there can be drug, there can be dilator, there can be surgery. Surgery is the most effective. But please remember this thing. Surgery also carries mortality because esophageal, any sort of surgery may carry some mortalities. Okay. Here's the thing given about the sensitivity and exclusivity, which I think we will add more this kind of thing in the bias. It will be more exciting to discuss this thing. This one is a sensitivity high and the specificity low, but we're not getting into brief discussion on this one today because it's better to keep it for the biostat day. Okay, so it's better. So here's a little reference about the curves. Those has been like towards A, more towards the people. Yeah. So We'll get back to this one with you. Okay, moving to the next one. Oh, okay. So today we had a little less, so because I wanted to discuss something important. Is some of the things like um, just taking a second, guys. So in a process of admission, so I think very sooner or later we'll be close the admission thing. Just trying to share special post with you guys. Okay, I'm reposting this one in the video channel. I hope certainly some of the doctors are added to that one. When at the time of taking admission, there was a link was given. I'm taking the screen just to share something with you. Okay. If you have any further like question about admission and this that, you can get back to me by inboxing or by WhatsApp. Here is a like a steps. Definitely, this will help you getting through in Australia. Of course, after doing the EPIC registration and this that, you all are here at this point. MC Part One, and after that, important ladder would be English test with a PT like 65. PT also helps in immigration, so it's vice versa important. Then we go for the job application actually. We get a job, then we apply for the registration process. Okay, and this is like interesting in Australia. When first we apply for job, then we get through the registration process. Now, there's a two thing. If you have experience, yeah, WT also accepted, IELTS also accepted. Great. Now, here is this case. Um, the jobs, especially after AMC Part 1, the job comes by limited registration. Job comes by limited registration. So after finishing the uh, registration, then they enter into the job. In the meanwhile, they will tell you that you try to finish the MC2 and keep doing your job because academic things they will be encouraging you a lot. Okay. Once you finish the MC part 2, you can um, use because you already started working, or you finish the MC1 and then you finish the MC2. Okay. And then you start working in Australia for like 1 year, covering emergency, covering medicine, surgical rotations, and you apply for the general registration. Once you get this general registration, then you are ready for everything, ready for applying extra job, which will give you extra money like locum. Then you can apply for the PR and the citizenship. So your target line is this one, guys. Is it clear, everyone? So your target is no matter what, you have to get the general registration. Now, if you have vast years of experience after MC Part 1, you took a different ladder towards the GP. The quick question, can GP give you the general registration? Not really. But can GP give you the PR? The answer is yes. By, for example, under that particular company you are working, they can sponsor so that with that sponsor, you can again apply for the PR and the citizenship. Is that clear to everyone? No? So it's more like that. GP thing is more like that sponsor thing actually. With that sponsor, later you can apply for again the PR actually. And if you get a general registration, it's straightforward application. Okay? Is it clear, everyone? So far, this particular ways. And there's another route. Let's not discuss about that one today. That's called WBA. But you can check in my YouTube. There's already video WBA or workplace based assessment. And you can type my name Shahriar Ahmed. You'll find that video. For that one, you already need to inside Australia. Then you can apply for the WBA program. So with the WBA program, again, you can get the general registration. WBA program is like a 1 year program. Under that one, there will be multiple exams, but for that one, you don't need MC2. Okay, so that's the thing. Great. Yes, this video I think we can upload in the YouTube. Last one we didn't. Yeah, I think we usually upload all our videos regularly in our video channel. I mean, in our Google Drive. Let me show it to you. Wait, guys. So if you join our course, let me show you how it looks like. Okay, when you join, this is how it looks like. So MC, this is the one recall course, and this is how it looks like, including MCSM and modes. 2024. Now, if we enter into 2025, yeah. So definitely these are the folder. Since we are starting the August, so there will be a new folder. And in July, as you all can see, when you enter, there's already pre-existing videos and this, that, so recently some of them we updated. So you can check them actually. So those of you who are already there, you check from the 2025. So I hope that is clear to everyone, right? Yeah. Now, YouTube is like sometimes sample video upload. YouTube is sometimes just as a sample video upload. Like normally, of course, we will not upload in YouTube, but probably this one, since it's a trial class, maybe we can upload actually. If anyone from outside, they want to see how we take classes, what we discuss, how materials looks like, this is how the things are. So you can see it's latest 2025. And also if you see some of the previous folders, if you check 2025 August will be also updated. Yes, in next 1 to 2 days we'll upload them, and you see every month is updated. December, January usually no exam in AMC. That's why you will not find in December, January. Same goes with the particular other years. Yeah. So yeah. So even if you enter into any particular set, so this is how things are given. All right. I hope this clear. Individual videos are like 2.5 hours, and there are files, and these would be really, really helpful, guys, actually. All right. So if anyone joined late, for them a little information before we wrap up is that um, if anyone is left over and interested in joining, I'm sharing my WhatsApp number. I think that'll be helpful for some of the doctors. Yeah. So this is my WhatsApp number. I'm giving you a minute before closing today. Yeah. So you can just get this WhatsApp. Me and my team both handles that WhatsApp. So if anyone's admission is left over, and for the class inquiries, do not inbox because it's usually managed by the team. So I posted something in our course group about the inquiry about the second class. So if you have any inquiry about the second class, usually try asking there, guys. Okay. Great. Yeah, you can just play any one of them. They will be played and you can just go through it actually. Yes. All right. So live classes and then 5 years recordings. We'll be also providing you a question bank. Once the group is closed, we'll be providing the question bank. And this is how the routine of this current batch looks like. Please note, our courses are normally, recall courses are normally January, April, and August, usually 3 months. And January, April, and August. So this one is the August one. And 5 months courses are usually, one is usually in December, another usually is in May, actually. All right, great. Both courses are wonderful. Till date, we have a very huge number passed, which is very promising. No one has able to did that, especially in AMC side. Yeah, it's been our um, long time, 10 years in MC. And we do have our, you know, particularly if you go to our pages, actually, I mean, MC online, we have two pages actually, MC online. Um, yeah, that's our page. If you go to our page, yes, yeah, it's also one of our old page, old verified page. So verified by, yeah, Facebook as well. Company verification are quite a difficult, but probably we didn't have much difficulties because of like the huge reviews, and you can see the number of reviews, 923. I hope if you like classes, you can also come up with reviews for us, recommendation for us in future once you pass actually. Or yeah, so good luck. Soon I think it will be 1,000 review um, by the candidate. So thank you so much, guys, and good luck. And definitely thank you all for attending. From next classes, we'll be adding more recalls actually, because yeah, it's a trial one, and I wanted to discuss additional one to thing with you guys, especially this job related and the basic step. Some people have this confusion. It is impossible to get job after MC Part 1, but you need to have a little more experience. If you're a fresher, then MC1, MC2, and then apply would be better. By this time, you try to enhance your CV a little bit would be more better. Enhancing CV will be also important. Also, small tip, when you with us in future, we'll also try helping, guiding you with certain things like curriculums and this, that we're adding more things in coming days actually. All right. So I think things would be helpful. Uh, Good luck to all the dear doctors who has joined us, and please make sure then step by step, okay, one step at a time, you can go through it, and things will be really, really, helpful for all of us to guide you. Yes. All right. Make sure you don't have much gap in your CV. Actually, that's more important. I do have a video um, in my YouTube. You can check, or you can type clinical gap and type my name, Shahriar Ahmed. You might find that video. Make sure you don't have longer gaps actually. Right? But anything it's possible to deal with. We have dealt with much more complicated cases in past actually. So don't worry. We are with you. Thank you. Good luck. Good night. Take care. See you in next class. So this batch will be closed very shortly. If anyone left over with admission, feel free to contact us. Good night.